Welcome to the podcast of Rotary Magazine, the official publication of Rotary International. I'm Linda Yu. 2023 is a critical year for polio eradication efforts. Wild polio virus is circulating in Pakistan and Afghanistan, with 9 cases so far in 2023. Additionally, the variant polio virus found its way to New York last year and was detected in other previously polio-free places. A stark reminder that if polio exists anywhere, it's a threat everywhere. But experts remain optimistic. Ukraine's polio outbreak was officially closed in September, despite the harsh conditions of war, showing just how prepared the Global Polio Eradication Initiative is. Rotary and its GPEI partners have the strategies and tools to achieve eradication, but only if we keep up the pressure on polio. To get an idea of the recent progress made and the challenges met, the Rotary Magazine team sat down with 3 experts across the GPEI network. Up first is Aidan O'Leary, the Director of Polio Eradication for the World Health Organization. In addition to his work at the WHO, Aidan was Chief of Polio Eradication in Pakistan for UNICEF from 2015 to 2017, and has served as head of the Office for the Coordination of Humanitarian Affairs in places including Yemen, Iraq, Syria, and Afghanistan. Aidan, it seems like you've committed not only your career, but your life to eradicating polio. So how did you become so passionate about this work?
Good morning, Linda. My introduction to polio was actually much more recent in 2015 when I joined the UNICEF team in Pakistan. And at that time, one of the major motivations for me was this extraordinarily ambitious goal that existed to essentially eradicate a disease and to join smallpox as only the second human communicable disease ever eradicated. And it's definitely something that I was very much interested in. But very shortly after I arrived, I started to get to grips with some of what I would call the more human elements. And in 2015, it was immediately after an outbreak of wild polioviruses that had resulted in nearly 360 children being paralyzed across Pakistan. And I will never forget the first investigation that I was involved in to meet basically the family of a child under 2 years of age that had been paralyzed by wild poliovirus in the southern part of Peshawar in Khyber Pakhtunkhwa. Unfortunately, we're dealing with situations of abject poverty. We're dealing with very difficult water and sanitation conditions. And on top of all of that, now we had, for the child, lifelong paralysis. And there is no cures. Once you're paralyzed, this is something that you do have to take with you for the remainder of both your childhood and for the remainder of your adult life. But what was probably critical for me was the engagement with the parents. And the parents were basically drawn from what would be described by the program as silent refusals. So they had challenges with acceptance of vaccine and vaccination, but it was clear that they had been listening to other voices, other advice, other guidance. But in their heart of hearts, they knew that if the child had actually received the drops of polio vaccine, their child wouldn't have been paralyzed, because polio is a vaccine-preventable disease. It's really important that we never forget the very human face of what lies behind these cases of paralysis that are recorded. As we work to eradicate this disease, what we're also seeking to do is to make sure that no child anywhere in the world is at the risk of paralysis moving forward. And I think that's in many ways much more compelling than the scientific milestone itself.
A lot of your work now is in Pakistan, and you talk about all of the different issues that they face there. Afghanistan also is the other of the last 2 countries that have not been able to eradicate the wild polio virus. There are even more issues there, aren't there? How do you tackle all of those many, many issues that these people face when it all comes down to each single child?
Afghanistan is an even more complex setting and situation at this point in time. So As things currently stand, we have more than 30 of the 40 million plus population are assessed to be in humanitarian need. So I think the first thing that we have to be clear about the context in which we're operating. We very much appreciate the fact that the health sector is the only sector at the moment where women are working in support of the delivery of healthcare. So if you're a man, woman, boy or girl, your prospects of actually engaging with a working woman is likely to be a doctor or a nurse working at a primary healthcare facility, or it's likely to be a female polio frontline worker delivering vaccinations in the key areas that we focus on. So I guess when we look at Afghanistan, the overarching priority was to reduce an estimated 3.5 million children, which were essentially inaccessible to the program. What we've seen over the last 12, 18, 24 months is a situation where that number has reduced to probably around 300, 350,000, largely concentrated in the south of the country. So I think we've made good progress. We did have a very specific challenge in the east of the country, which has been the source of most of the detections that have been recorded. So this is in the province of Nangarhar. We've seen the quality of our programs continue to improve to a point where actually in August of this year, for the first time in probably kind of 12 to 15 months, we have not been able to detect the wild poliovirus anywhere on the territory of Afghanistan. We're not out of the woods. What's going to be really important is we maintain and intensify the momentum that we currently have to, again, continue to work to make sure that our children are protected.
It sounds like there's acknowledgement by the Taliban that health workers need to be there taking care of people. So tell me more about the Afghan government's cooperation with organizations such as the World Health Organization.
For a program like polio eradication, the key driver is to make sure that we have acceptance, confidence, and trust at community level. In large swathes of the country, the best way to maximize acceptance, confidence, and trust is to ensure that you're engaging with a female vaccinator, with a female medical practitioner, nurse, birth attendant, as the case may be. So I think the important thing simply is to demonstrate, in accordance with Afghanistan's own social and cultural norms, every time we would do a national campaign, somewhere between maybe 20 and 25% of our workforce is made up of women serving their local communities. What we really want to do is build upon and strengthen that trend and momentum. This isn't a question of ideology. This is a question of basic program delivery in the way that best works and using norms or customs that are fully accepted in country. And as we make more and more progress in Afghanistan, the results will ultimately speak for themselves.
Looking at and listening to previous interviews that you have given, the thing that I hear most from you is we must find and vaccinate every last child. So how do you find all of them? How do you find the polio virus? How do you do all of that in a situation like Afghanistan?
For me, the most important part of the program is our surveillance system. And our surveillance system is made up of essentially two approaches. So if we have a situation where a child presents to a clinic or presents to community health workers, we basically take a sample if the child is demonstrating symptoms of acute flaccid paralysis. We want to make sure that the child is properly diagnosed. So we basically have a system of testing through laboratories to determine whether or not the wild poliovirus is at play. We investigate the wastewater in the sewage systems across the country for presence of the virus. So we listen to what the virus is telling us, because the virus is already found where all the weak points actually are. We then pursue a range of response options to interrupt that transmission that has been detected. So we know the virus will never lie, and we also know that the virus is ultimately fighting for its survival. So what we need to do is to maintain very extensive surveillance to make sure that our intelligence system is picking up any signals that it may be around. And then we need to plan strategies and modalities towards maximizing the coverage of children in these areas. The communities also have confidence that once we detect, we are also going to assist with the response. That response is ultimately around making sure that we build up as rapidly as possible the immunity of all children in those areas, recognizing that actually it's the infants and children under 2 years of age are those that are more vulnerable. Because it's these younger children, they will not come outside the homes, which means that as we go house to house to reach these children, we need to have the acceptance for our female vaccinators to enter the home and make sure that all the children inside are properly and fully protected.
I'm suddenly struck by when you said the virus wants to survive. Does the virus change then? Does it adapt in order to survive? So the vaccine has to change?
The wild poliovirus has been with us for millennia, back to ancient Egyptian times. So how does the virus survive? It goes to areas of inaccessibility and insecurity, disputed borders. It relies on areas where there's no surveillance, where there's weak immunization, where there's complacency. Today, we're looking at a virus that has been narrowed down in terms of wild poliovirus endemic transmission to a single province of 34 provinces in Afghanistan and to a single district amongst nearly 160, 170 districts in Pakistan. So we're being very vigilant. We're trying to address the historical avenues that are pursued by the virus to try and break out. In the last 18 months, we discovered wild poliovirus that originated in Pakistan, in southeastern Africa, detected in Lilongwe in Malawi, and then subsequently in Mozambique. Again, what the virus is doing is migratory patterns to get to a place where it's not under this relentless pressure that the program is putting it under. So with the support of both governments, this was very, very quickly stamped out in both Malawi and Mozambique. We have had no detections anywhere on the African continent since August of 2022. But what we're dealing with now in Afghanistan and Pakistan is much more localized efforts for the virus to try and escape its endemic transmission zones and therefore survive. So it's not new vaccines. It's for us to be really aggressive in terms of our pursuit of the virus in the endemic zones, but equally vigilant in terms of any new detection, whether it's through the wastewater system. As it stands in Pakistan now, any detection in wastewater is resulting in between 2 and 4 million children being vaccinated within a matter of weeks, and then additional rounds as needed. And it's all geared towards making sure that the virus cannot reestablish transmission anywhere else. So it's a very long, very difficult road. What's important is that we keep closing in on zero and cutting off those avenues for the virus to escape. And that's really what the program is about at this point in time.
We've heard about some outbreaks of the circulating variant poliovirus in polio-free countries. So what's the difference between those and the wild poliovirus, and how do you stop this other one?
The first thing is the wild polioviruses have been with us through the millennia. So they're essentially the original of the species. What we're actually left with now is wild poliovirus type 1. What has already been declared as eradicated is wild poliovirus type 2 and wild poliovirus type 3. When we speak with the polio variant viruses, what we basically have is a kind of paralysis that takes place where a live virus is able to circulate for extended periods of time, usually a number of years, in communities that are either unimmunized or underimmunized. You did mention the situation in New York and London. So absolutely, if there's a gap, the virus will find a gap. The message is we need to have good surveillance. If there's any detection, we need to know before a child gets paralyzed. The other part is that we need to be really clear about where the gaps in our immunization systems are. So in the US, in Europe, there's very strong immunization rates overall, but there are pockets of underimmunized communities which we have to be more systematic in terms of how we work to close the gaps. We saw the initial detections in the UK and the US. It's clear that pretty effective action has been taken, but it is a very cautionary tale that for as long as we have transmission anywhere, potentially everywhere is at risk.
Every partner in the GPEI has a specific strength, maybe several strengths. Can you talk about what strengths Rotary and its members have brought to this?
GPI is extraordinarily fortunate to have Rotary International as a partner in this initiative. And in my experience, I've always been humbled by the way that Rotary interlocutors that I've had have always been able to find a way to talk to somebody who knew somebody, who knew somebody, who knew somebody. I mean, for me, that's a huge part of what Rotary actually brings at the country level. More broadly, I think Rotary is an extraordinarily strong advocate in all of the major fora, recognizing that political will is absolutely essential for us to finish the job. And then I think, last but not least, Rotary has proven to be a very major funding partner. And 1 in 6 of every dollar that the program spends in support of what we seek to do is essentially enabled by Rotary International. So certainly on my side, always hugely grateful for the huge effort. I was most recently with the Rotarians at their conference in Manchester. It never ceases to amaze me, the extraordinary enthusiasm, the willingness to understand and listen to where the program is at, and essentially recommit towards making sure that the job actually gets done. So for me, a really big thanks to Rotary International.
When can you say that there is no failure because there are 0 cases?
Certainly for the wild poliovirus, the importance for the program of maintaining the existing intensity and momentum as we work through what is called the high transmission season, which is basically during the summer months. A good job has been done in terms of containing the virus. What is really important for us is that the virus does not survive the next low season. We're in a really reasonably good place in relation to Pakistan. There's clearly ongoing work in relation to Afghanistan. So I would hope that come next March, April, May, there will be more positive news to report in relation to the trajectory on wild polio.
Keep working at it. Thanks to Aidan O'Leary of the World Health Organization for joining us. Next up, we welcome Melissa Corkum. Most recently, Melissa was the Senior Manager for Polio Outbreak Response in UNICEF, co-leading the Global Polio Eradication Initiative's Outbreak Response and Preparedness Group. When we interviewed Melissa, she was getting ready to move to Pakistan, where she currently serves as chief of the polio team there. Joining us is Melissa Corkum of UNICEF. Melissa, a lot of progress has been made since 1988 when the GPEI was first launched. Now, talk about that improvement and what that really means for the health of the children of the world.
Great question. So I think if you can imagine, put it in a perspective that every hour, 40 children were being paralyzed by polio when we first started. Well, in fact, Rotary first started the polio eradication program in the 80s. Polio was circulating everywhere in the US and other countries. Summer swimming pools were shut down because of fear of polio. And so, it was paralyzing 350,000 kids at least every year in more than 125 countries. But since the launch of the program, now we can count the number of polio cases, children being affected by polio, on our 2 hands. So that's amazing progress. In fact, wild polio is endemic in just 2 countries in the world, Afghanistan and Pakistan. And so it shows the results of what can happen when partners pull together to collectively fight a disease. I look back to my time I was in Nigeria, and polio survivors were on every street corner, very noticeable in their unique chairs, and it was visible. Now you're not seeing that so dramatically just because of the focus on reaching every last child.
So you're going to Pakistan, and you've talked in the past about the micro planning that it takes to reach every last child. How do you conduct the surveillance? Why is all of this micro planning also so important?
So surveillance is fundamental to the eyes and the ears in terms of a polio campaign. Microplans, I'll just give a context. A campaign in Nigeria is 71 million children. That's our target. over 4 or 5 days. So, and house to house. So you can imagine the micro details to know where the children are, where the houses are, and making sure that we're reaching children where they are, whether it's schools or if children on the move, if they're at their farms, planning where, when, and how the vaccination teams are going to reach every child, and how many ice packs, the social mobilization, getting the trust of the communities. So it's an incredible undertaking when you're trying to reach 71 million kids over the course of 4 or 5 days. The micro-planning is fundamental to enabling us to do that.
There are countries that they may not trust a vaccine. They may have heard rumors. There may be cultural issues. Are there still those kinds of problems, or are you looking at places where there is at least basic government support of the eradication efforts?
In most countries, they're leading the eradication initiative, and we work very closely with the ministries of health at all levels, whether it's at the national level right down to the local level. What boils down to is trust, and that's trust in who's delivering the vaccine. That's why getting local frontline workers delivering vaccines or mobilizers from communities who are known in those communities becomes so important. But holistically, if you look at the big picture, there is widespread acceptance for polio vaccination, but it's really in these hard and challenging geographies like northwestern Pakistan and the Khyber Pakhtunkhwa province. Challenges remain in very geographically focused areas.
Talk about the women, predominantly the women who go door to door, find the children. How do you train them? How do you get them dedicated to doing this work?
Well, female polio workers are essentially, for me, they're at the heart of building trust and reaching all children in their communities, especially in areas where cultural norms prevent men from entering the houses, like places like Pakistan, Afghanistan, and northern Nigeria. Just the sheer size and scope in many of these places, the numbers of health workers are very small compared to the mission that we have to go in. So, to engage females, you got to start at the community level and working through local community leaders and elders so that they're part of the decision-making process and connected to the communities. First and foremost, in terms of trust, anyone that's knocking on the door really needs to be from those communities and trusted by those communities. And females are, as evidence has shown everywhere, can make that happen and have been successful in opening up doors to reach all the kids under 5, especially the newborns.
So in addition to having women who know the community and the community knows them, what else do you need to do in terms of educating parents about the safety and the necessity for the vaccine?
So social behavior change communications, engaging with communities becomes so critical. It's context specific. In a remote slum in urban DRC Kinshasa, your approach would be very different than in a place like a rural Zamfara in Nigeria. So everything needs to be tailored to the local context of who you involve from the communities. Of course, media and all those things play an important role. And of course, now the digital space has become so important, but at the heart and soul of reaching into households, the community leaders, the women's leaders, polio survivors themselves have become so critical to getting credible information out in these communities themselves.
I hadn't thought about that, to get the survivors themselves to it.
Polio survivors, we had thousands of them involved in northern Nigeria and in areas where you have issues with trust in vaccines. Polio survivors can convey an incredibly important message visually, but also from their heart and their own experience.
There's an interview that you gave, and you said, we can't miss the same children. Talk to me about what you meant by that.
We need to find those missing children and make sure they're part of our microplanning. And that includes the most rural, remote settings, but also those that are right under our noses in urban slums. Urban areas can be incredibly complex. And if we continue to deliver to the same kids and miss those that tend to be the most deprived in terms of routine immunization, nutrition, etc., we're not going to be able to achieve our goal.
I also think about how difficult it is for you and the other workers, because you may have been able to get into a community, reach those children, and then a couple of years later, the situation in that community, politically maybe, or community leaders, has changed. And you have to find another way of getting back in to those children who've been born since you were there.
Nothing stays static. In some countries, Pakistan, Afghanistan, the numbers of children that are crossing the border every day, kids are on the move. Nothing stays constant or forever. New children are born, children move in, children move out. If you look at Sudan, we did one campaign and the next campaign we had to put on hold simply because the whole context changed with the recent insecurity and conflict. So the program needs to be adaptive, creative, and innovative.
Was COVID a huge setback in many ways?
COVID set us back. We put the whole program on hold for many, many months. When you stop immunizing for a period of time, outbreaks spread, children move from one country to the next, nothing stays static. So we saw huge uptick in the number of cases, and it also affected wider immunization rates. So, health systems were stretched, health workers were stretched. So that affected wider childhood immunizations, COVID, measles, Ebola for some countries, Nigeria, for example. All of those frontline workers got involved and supported COVID, but more wider health responses, measles, for example. So the investments that we've made into polio can be used to support wider public health responses. One of the legacies of this program is the people, the knowledge we have. Microplans can be shared. Maps can be used. Those social mobilization networks, surveillance networks can and have been repurposed to support wider public health, but also emergency responses. I was in Nigeria on my way to a meeting when we got called to go to the EOC because we had to respond to the Ebola outbreak. So polio took a step back and everyone rolled up their sleeves and got involved in that current public health emergency because we had the know-how to deliver quickly and had the knowledge of communities because we're delivering at the household level.
So, Melissa, we've heard about outbreaks of the circulating variant poliovirus last year in places including New York and London. So how do you stop such outbreaks and prevent them?
Until we finish polio globally, we're going to continue to face outbreaks. And so in those areas where we were missing kids, and we have under-immunized kids, this is where we continue to face challenges with outbreaks. But it's the same approach to putting an end to a variant outbreak as we are doing in the countries with wild poliovirus. Getting drops into the mouths of the kids as quickly as possible is how we achieve success. Doing it quickly and raising the alarms into countries where they haven't had polio for a long period of time, like New York, like the Londons, to make it a priority amongst everything else and to a forgotten virus is one of the big challenges. And that's quite different from Pakistan, Afghanistan, the endemics, which have had polio around for a while.
With all of the progress that's been made, are you confident that we're close to polio eradication?
We are close. Polio is cornered in just a handful of geographies, not even countries, small pockets of geographies, districts, 3 provinces in the eastern DRC, 4 states in northern Nigeria, small districts in Khyber Pakhtunkhwa of Pakistan. So I think there is tremendous progress. It's not just about the numbers of cases, it's the fact that it's cornered in really, really small places with, actually very few children in the wider scheme. So I think we've never been this close before, but that progress is incredibly fragile. We need to have laser focus on reaching all children in those handful of places towards the goal.
Thanks to Melissa Corkum of UNICEF for giving us your perspective. Finally, Dr. Omotayo Bolu is the Polio Eradication Branch Chief for the U.S. Centers for Disease Control and Prevention. She's been working in immunization for over 20 years and was formerly the Country Program Director for Immunization in the CDC Nigeria office from 2016 to 2022. She sat down with Carol Pandak, the director of Rotary International's Polio Plus team.
First of all, tell us a little about your experience in Nigeria and what role you played in polio eradication efforts there.
So I was the program director for the immunization division in the CDC office in Nigeria from 2016 through 2022. And my role was really to provide strategic guidance, technical support, and implementation of polio eradication efforts. I worked very closely with WHO, UNICEF, Rotary, the Bill and Melinda Gates Foundation, and Gavi towards coming up with one plan to fight polio. During my tenure, we were able to certify Nigeria as polio-free, and that worked for the rest of Africa.
Well, congratulations to you and the team, because you successfully did reach the goal of a wild poliovirus-free Nigeria and Africa. Are there any lessons that you learned in Nigeria or in the African region that can be applied to the two remaining endemic countries of Afghanistan and Pakistan?
Absolutely. Some of the issues we see in Afghanistan and Pakistan are similar to what we saw as a polio eradication team in Nigeria. First was we were able to move the viruses from being widespread across the country to one small geographical area that is in Borno State in Nigeria. And right now in Afghanistan and Pakistan, the viruses are really in very few geographies. The second was coming up with innovative ideas. We innovated every day to reach every single child because different areas had different issues, from banditry to insecurity to hard to reach areas, including getting to the nomadic populations. We used innovations like ring fencing, meaning where we could not get into, we would have teams walk around that area to restrict any further spread from that particular subnational geography. We worked with community informants, we worked with the military, we worked with the vigilantes who were able to vaccinate children. But we also were very granular in terms of the epidemiology and the data. So counting down each time we put in place an intervention, checking to see how many children were remaining that we had not yet reached.
Those are really excellent examples of how experience in one place can certainly be applied elsewhere in the polio program. Can you talk a little bit more about surveillance and its importance to the program and what role it will play when we reach our goal of a polio-free world?
There are two major ways in which we take to detect the poliovirus. One is testing the stool of individuals with acute flaccid paralysis, that is, persons with acute paralysis for poliovirus. And then the second is supplementary testing of sewage samples to detect if there is polio in the environment, because people with polio tend to shed the virus and it goes into the sewage system. For every 200 persons who are carrying the poliovirus, there might be only one person with the paralysis. But yet, if we see it in the sewage, through surveillance, it tells us that we have transmission or circulation going on and we need to act fast. The sooner you can detect an outbreak, the sooner you can respond to it, the less likely it is to continue to transmit and to cause further paralysis.
What do you think needs to be done to finish the job in Afghanistan and Pakistan? As you said, there are particular challenges in those countries. How do you see the way forward?
One thing that's happening between Afghanistan and Pakistan is we see it as an epi-block. They are so closely linked together. We would like to treat them as one group. And so synchronized campaigns, meaning when we do a campaign in Afghanistan, we're doing the same in Pakistan. We need to ensure that when we are reaching children in one area, we're reaching them at the other side and there's no cross-transmission. The second is the insecurity. We're advocating with the leadership to address the polio, because polio does not recognize which group you're in. It just recognizes a child. And so dealing with the insecurity like we did in Nigeria, working with the vigilantes, working with the military, using community informants, people that actually live in the communities of insurgency, working with them to help give the vaccines will be important.
I had experience with these volunteer community mobilizers when I was in Nigeria not too long ago and was out in the field with frontline workers in Pakistan just this past June. And, they're immunizing against polio, but they're also talking about other important health interventions to keep children well. Can you tell us a little bit how the polio infrastructure is being used to support other health priorities in communities?
We say once we get to eradication, there would be a transition to other programs, basically to essential routine immunization, making sure that the capacity that has been built through polio can support strengthening of routine immunization, using the staff and the people like the community health workers and the female volunteers to raise support for other services. So they don't just go from door-to-door giving polio, but they also encourage women to come into the facilities for other services. In Nigeria, they have a program called the CHIPS, Community Health Influencers Program, where they are converting and using these polio volunteer workers to provide other services, getting the women to come in to get their antenatal care, come in for their delivery, using these same polio workers to also give, if it's vitamin A or other water and sanitation. Right now, we're focusing a lot on the polio surveillance as a GPI, but we're beginning to have discussions and processes in place for how do we integrate the polio surveillance into the broader vaccine preventable disease surveillance. So the broader surveillance systems that would be used for measles, mumps, rubella, for other vaccine preventable diseases. When we finish the job on polio, all that capacity, all that strength, all that knowledge is used for the broader VPDs, is used to strengthen routine immunization because we're already working with them. During COVID-19 in Nigeria and even at CDC Atlanta, we used the polio EOC staff to set up and support the COVID-19 response, the incident management structure, the surveillance for COVID-19, patient tracking for COVID-19, case management for COVID-19.
Do you have any thoughts on what are the unique characteristics of Rotary and our members in the Global Polio Eradication Initiative?
Absolutely. I'm personally awed and impressed by the work Rotary does. And the biggest thing I've seen Rotary do, both in Nigeria and since moving back here, is the ability of Rotary to advocate and mobilize resources from the program. So I do want to give kudos to Rotary on the ability to advocate, to go to the Hill, to push for resources for the global polio program. Even for us at CDC, we benefit a lot from that, all the GPI partnership. The other big area is you have a Rotarian in almost every sub-national geography. And you have teams of Rotarians that help when we do campaigns. And Rotarians push on World Polio Day. So many times I have at least 2 or 3 Rotary aprons that I wear, and I go with Rotarians, and we monitor campaigns together to either correct the vaccinators if we see that they've missed a child, or to also assess how well they're using the resources to reach every single child.
Yes, certainly Rotary has invested over $2.6 billion in the global effort to eradicate polio and, as you say, advocates at the country level from the most senior levels of government to the most local levels of government and influencers. Recently we've seen some polio cases and detections in sewage in countries that haven't had polio for decades. So what is that signaling to us at this point in the global polio eradication effort?
The fact that we've not seen polio for 20 years, 30 years in some countries does not totally mean that they're 100% immune. It's the case of an outbreak in one country can happen in another country. And the reason why we do see outbreaks is due to the large numbers of sometimes unvaccinated persons and the importation of a virus into a place that hasn't seen a case in a long time. So if you have unvaccinated people or people that have not gone for their vaccines. And if there's importation of polio from another country that is experiencing an outbreak, then it puts that individual and that country at risk.
I think that's an important point. Yeah, that while poliovirus circulates anywhere in the world, it is a threat to people everywhere in the world. And World Polio Day, October 24th, provides the great opportunity as a point in the calendar where we can focus on the importance of polio immunization and immunizations writ large. Thank you, Omotayo, for your time today. It's been wonderful speaking with you, and we appreciate our partnership with the U.S. Centers for Disease Control and Prevention and look forward to working with you until we achieve the goal of a polio-free world on behalf of children everywhere. Thank you.
Thank you so much, Carol. And I really appreciate on behalf of CD the partnership. It's been excellent, and we will get there. I'm optimistic that we're almost there, and we just need to continue to push. Thank you very much.
Thanks to Dr. Omotayo Bolu and all of our guests for updating us on the state of polio eradication. This episode of the Rotary Magazine podcast is produced by Kristen Morris and JP Swenson, edited by Wen Huang, with production by Yusu Kim and Tim Kapp. Special thanks to Sarah Tetzloff and Carol Pandak for helping us research and produce this episode. To learn more about Rotary's polio eradication efforts, visit endpolio.org. I'm Linda Yu. Thanks for listening.